a C-spine trauma patient, and then we'll eventually get into a couple of interesting cases that my colleagues here have put together. So, yeah, so essentially, cervical injuries account, it doesn't account for the majority of orthopedic trauma, but it accounts for a sizable percentage. But the impact that it has is pretty substantial. So we're seeing about upwards of 20,000 new spinal cord injuries annually, most from cervical injuries, and a good portion of them have pretty significant deficits. As with most trauma, we sort of have that classic bimodal distribution where it's sort of high energy injuries in the young and low energy mechanisms in the elderly, which we're seeing a lot more of, particularly with like sort of our aging demographics here. Yeah, we have sort of what, many have coined the silver tsunami that's sort of coming, and we're really seeing this clinically. We're treating a lot more, we have a lot more patients presenting to our hospitals with central cords. Feels like it picked up a lot, after the pandemic. But the mechanism for most of these injuries, like most are motor vehicle collisions and falls. These account for the vast majority of our injuries here. And so the initial workup, when someone comes in and they're undifferentiated, is really based in sort of our ATLS guidelines. So we assume that every patient has an unstable C-spine injury until that's been ruled out. And so the initial evaluation, once you meet a patient, you're getting a pretty good history of the mechanism, what deficits they may have, and especially in our elderly patients, whether they're on any anticoagulations, because that's going to raise or lower our suspicion for an epidural hematoma. And then next, of course, is a pretty comprehensive physical exam, examining for tenderness, a comprehensive motor and sensory exam, and of course, a rectal examination to evaluate the competency of the most distal nerve roots. A lot of our patients, these spine trauma patients, only 50% of these of spine injuries are isolated, which means in about half of patients, there's another significantly injured system. So TBIs are pretty common, facial injuries, especially in the presence of a cervical spine injury, blunt thoracic injury, injury to the arms and legs, and of course, non-contiguous C-spine injuries, as sort of you can sort of see here in this picture here. So if we identify an injury in one portion of the spine, depending on the series, there's roughly a 10%, sort of rate or prevalence of another non-contiguous spine injury. So a lot of times our eyes will focus on like a pretty catastrophic injury, but we also need to evaluate the rest of the spine. So in terms of our imaging modalities, the X-ray, CT scan, and MRI are the three modalities that we rely on. Historically, X-ray was the imaging modality of choice. However, in order to adequately evaluate the cervical spine, you need to be able to visualize all the way down to C7 and T1. In a lot of our patients, you can't, with a lateral C-spine X-ray, you really miss that region of the spine, which is problematic because the majority of our cervical injuries actually happen in the lower, at the cervicothoracic junction. And so now, in the current era, CT is favored as the initial imaging modality of choice. So what CT offers, it offers a pretty high sensitivity. Once you account for the rate of missed injuries, it's cost effective. It can provide some indirect evaluation of the ligaments. So if you see some splaying of the spinous processes, that will sort of cue you into potentially a posterior ligamentous disruption. And if someone eventually needs to undergo surgery, it provides, it characterizes the bone to characterize a fracture, as well as for surgical planning. A lot of our trainees, like one of the questions that they have is sort of, how do I systematically go through a CT scan for trauma? And we can do this pretty systematically. I think I remember one of my chief residents when I was younger, just thinking, is like, if you do these things sort of in the same way every single time, you're not going to miss any catastrophic injury. And so for our CT scans, we have our sagittals, our axials, and our coronals. And this is sort of one methodology. As long as you do, go through all these aspects in whatever order works for you, that's, it's fine as long as you sort of do a complete evaluation. Prefer to start with the sagittals because this is where I'm going to catch most catastrophic injuries. So we'll start off on one side. We'll evaluate the occipital, the OC junction here. So you could see this occipital condyle. There's some distraction here, so this is not normal. So the sagittal, allows you to evaluate for an AOD. The other thing that you're looking on the parasagittal imaging is that all of the facets are appropriately shingled on one another. So you do this on one side, evaluate the left OC joint, evaluate the left-sided facets, move over to the contralateral side, do the same thing on the other side. The next thing is then to go to the midline and assessing our longitudinal lines to evaluate for any sort of subluxation that may be present in the presence of some injuries. And then in the midline, we can also evaluate for any midline soft tissue swelling. So our initial parameters for soft tissue swelling were really developed on the lateral C-spine x-rays, but these values also hold on CT scans. So the mnemonic that I tend to remember is 6 at 2 and 2 at 6. However, you need to remember that the units are different. So in the upper cervical spine, we're looking at 6 millimeters at 2 and 2 centimeters at 6. The area in between here, we don't really have characteristic numbers because it really depends on the phase of swallowing. So this esophagus could go up and down. Really, if you just remember these two numbers, you'll be in pretty good shape. And then once I make it through the sagittals, we'll make our way through the axials. And what you're doing is you're evaluating to make sure that there's a continuous ring at every single level. This is sort of the point that you're going to catch like your non-displaced lamina fractures, your non-displaced pedicle fractures. And then on the coronals, a lot of times we tend to overlook it, but it's really a great series to evaluate upper cervical injuries. Some of the cases you'll sort of see where part of the diagnosis is made on the coronals. So, and what we're evaluating here is the occipital, the OC joint here. So this is one that's injured. There's some distraction here. In some C1 ring fractures, you can evaluate the overhang between C1 and C2 on this as well. We also rely on MRI to some degree. So the MRI can characterize epidural hematomas. It can evaluate disc injuries. These are aspects that aren't really captured by the CT scan, which delineates bony injury really well. It can give us some evaluation of the PLC. And in the cervical spine, it gives us what we probably use this the most for is to evaluate for any ongoing cord compression. So in this sagittal cut here, you can see that the cord, which is usually this homogeneous gray, has some heterogeneity here indicating some acute injury. The initial management for any patient is, initially we start off by immobilizing them until we've ruled out an injury. And so historically, while in the 1980s, only 20% of spinal cord injuries occurred in patients over the age of 65, we anticipate that this age group will account for about 40% of injuries within by the end of the decade here. We're not going to spend much time on the management of spinal cord injury. But in general, we're referring to injuries. Any level at this, at the C-spine. That's what we're sort of referring to. The key is trying to, for the initial non-surgical management, is trying to maintain spinal cord perfusion. Again, the detailed evaluation is, sort of. We have our INSCI exam here. And really, this is the only slide that will sort of focus on this, but we're really trying to prevent any ongoing injury or secondary injury. So if someone has an unstable spine, you don't want to keep dinging that cord. So that's where stabilization with that spine board sort of plays in. We initially want to maximize spinal cord perfusion. This is very evidence-based. There is some role for pharmacologic treatment, and of course, physical intervention. So the quicker that we decompress something that's compressed, the better for prognosis. So this takes us to our operative indications. So For C-spine trauma, our indications are pretty straightforward. We want to decompress what's compressed, we want to stabilize what's unstable, and we want to prevent late deformity. And so even though, and this is, maybe arguably a little bit simplistic, because the next question when it comes to stability is how do we actually define stability? And the classic white and Punjabi definition is something that we can really hang our hats on. So defining instability as the loss of the ability of the spine under physiologic loads to maintain essentially its alignment so that there's no additional neurologic deficit, major deformity, or incapacitating pain. And I highlighted the physiologic loads here because our CT scans and our MRIs are supine studies. So even though we don't rely on X-rays as our initial imaging modality, it does, plain radiographs can play a role in trying to assess what's happening to the spine under upright, when the patient is upright. And so here's sort of an example of that. So here's a patient who has, between C4 and 5 has some facet fractures. There are plenty of papers that, try to predict whether or not this is going to be stable based on the amount of the facet that's involved. We can, relying on those, we could say maybe there's 40% will go on to, to be unstable. But for this individual patient, it doesn't really, those numbers don't provide guidance as to whether we could potentially treat this operatively or non-operatively. And so one easy way is to get upright X-rays. So this is this patient's upright X-rays. The upright alignment is maintained. And so this is someone where it would be reasonable to consider an initial trial of non-operative treatment with bracing. So the upright X-rays can provide especially when the CT scans and the MRI don't provide aren't indicating something is clearly stable or clearly unstable. It's the upright X-rays are very useful in the neurologically intact patient. All right, so in terms of the introduction, that's sort of what we have. And let me turn over let me see how to do this. All right, we'll turn it over to Dr. Theologis. Yeah.
Good evening, everybody, and Ash, great talk. Many of the principles that you discussed will be highlighted in this case. So this is a gentleman that Ashraf and I actually took care of together, and it's nice to share a collaborative case. So in terms of the initial presenting information, this is a 56-year-old gentleman who fell and hit his head while he was skiing. At the time, acutely, he presented with quadriplegia for 1 hour. This occurred in the mountains close to where we live in the Sierra Nevada mountains in Lake Tahoe. He had return of bilateral arm and leg function, but after the next day or so had persistent left arm pain and weakness. He felt that his right hand was slightly numb with handwriting changes, and he had loss of function of the left hand that was worse than the right. He was right-handed. And he also experienced bilateral facial below the eyes and above the eyes and occipital pain. One pertinent medical history is that he has a history of squamous cell carcinoma of the glottis that underwent prior neck radiation, no prior neck surgeries. So these were the initial presenting X-rays up in Lake Tahoe. You see the lateral X-ray and the AP, which doesn't give us a lot of information about the upper cervical spine. But on the lateral, it's pretty subtle, but there's some hyperextension that you see through the C2-3 disc. But I wouldn't say there's any frank displacement of the pars. And these X-rays looked not normal, but I think had a relatively quote unquote benign looking injury pattern. On the CT scan, you can see on the left is more of a mid-sagittal cut. And then in the middle, you see a cut of the body a little bit asymmetric to the left. Looking at the coronals, you can see that there's a mid-body fracture. There may be some mild comminution, but I think it was really a relatively clean break. And it does involve that left C1-2 articulation. And then if we look at the more sagittals a little bit more bilaterally, you see that there is bilateral pars fractures. one that involves that joint. So that mid body kind of extends up into the joint as well as the pars. And then you do have a displaced pars fracture on the right side. So it's a hangman fracture variant. So an MRI was obtained at the outside hospital, and there is some swelling and prevertebral signal and some soft tissue edema that you see there that extending from the C1 anterior arch down to about C4. And then if you look at the stir images in the middle, I think there is an injury to the ALL there at the base of the C2 body, but there's no frank cord compression. And so as locally, he saw a surgeon in that region in the mountains who recommended bracing initially. They put him in a brace, not a halo, but a cervical collar with an occipital extension, which you see this little pad up towards the base of his skull. And it is subtle, but I do think there is definitely a subsequent displacement of the fracture. You can see now that the C2 body is more hyperextended, and there's quite a bit more space through the disc at C2-3. So this is what they sent him out with, and they told him to follow up locally in San Francisco. Our chairman asked me to see this guy, and we plugged him in. And these are the presenting x-rays that we saw. And to us, you can see that his physical exam in the center there, his right arm was strong, except his interosseous, and his left arm had more noticeable weakness, the delts, the triceps, and also the interossei. And then he did have no hyperreflexia, but did have bilateral Hoffman's and no lower extremity upper motor neuron signs. So we got a repeat CT scan, and you can see here the subsequent displacement. Again, quite a bit more gappings through that disc in the front, and anterior translation of C2 on C3, a slight spondy. That posterior aspect of the C2 body is slipped forward relative to the posterior wall of C3. And then we got a repeat MRI. We wanted to see if there was any new cord compression or if there was some etiology for the persistent arm symptoms. And we did find that there was a new cord signal change in the posterior and the dorsal columns, but also in the center. And probably this is secondary to it being unstable and this hyperextension and that ligamentum flavum infolding, dinging in the cord. Probably every time he stood up. We also got an MR neurogram, the left brachial plexus. We wanted to see if there was any traction issue causing the left arm weakness. In skiing accidents, they can be pretty aggressive, and whether it was just a focal issue with the neck or if it was something extraspinal, we wanted to have that preoperatively, more for setting expectations for what may occur postoperatively. And interestingly, we did find that there was increased signal in the left C5 through C8 nerve roots along the respective trunks and divisions, and some associated edema involving adjacent scaling muscles, and then early degenerative change of the left trapezius and shoulder girdle muscles. The right side was actually normal. So in summary, we saw this gentleman about 3 to 4 weeks after a skiing accident with a documented unstable C2 hangman's fracture, has new dorsal angulation and ventral translation associated with core signal chains and a left brachial plexus traction injury. So for the plan, we did think that there was no controversy here in terms of non-surgical versus surgical. It definitely met the criteria for instability, was given the subsequent displacement. So we placed this gentleman on a levo head holder, used that to reduce the fracture, hyperextend it. And these were the x-rays after the reduction in the middle. And this may be slightly increased angulation dorsally of the C2, but I think it's pretty nice. And then we did a instrumented posterior fusion from C1 down to C3. We didn't think that a C23 ACDF would be needed at this time. I think the history of the neck radiation also pushed us away from that. And we felt that that would be kind of a bailout if he had issues healing the posterior instrumentation. We followed him post-operatively, and he had proved his neck pain was significantly better. He also had occipital and facial pain numbness that improved significantly, although not resolved. And then his arm symptoms on the right improved, but he had also improved in the left, but definitely not back to normal. We got a CT scan to assess the instrumentation as well as whether he achieved union. And you can see here both pars and the body healed. And so we thought that he actually did quite well. And happy to take any questions.
Alekos, looking at the initial X-ray, that you could see that there was a lot of soft tissue, prevertebral swelling initially. That was just another salient point that I wanted to point out when looking at the lateral.
That's a great point. Let me see if I can go back.
Yeah, you see a fair amount of it over there along C2.
That's a great point, David. That definitely would meet the criteria that Ashraf had talked about, which is it's subtle. And if you're not looking for it, you definitely overlook it. I think it gets to your point, Ash, about evaluating things systematically, not just focusing on the bones, looking at the soft tissues, and doing it the same way every time.
Yeah, no,
I know.
yeah, and I think and I think this case really highlights that even if someone is, appears to be, where there wasn't any translation on the uprights initially, but just that first, the subsequent X-ray that we have, sort of at the 3-week mark, you could see some translation at that point. So really following these patients where there's any sort of question, and so yeah.
If it wasn't for the history of radiation, would you have gone anteriorly at 2-3? Because that just looks ripe for ACDF there, just because of the obvious big soft tissue disruption through the disc.
Yeah, I think I would definitely consider doing C2-3. I'm not sure that would have been enough on its own, but
No, combined with the posterior, obviously the fractures posteriorly, but the soft tissue injury anteriorly.
yes,
Yeah,
I think
not as a standalone.
Yeah, I think that would have been a very reasonable approach.
Alekos, and what made you suspicious about getting the brachial plexus imaging, which I think is brilliant because maybe that's why he still got some interosseous weakness down the road. What was it about the history, the mechanism of injury, or just you kind of smelled this out from previous experience? That was a brilliant stroke.
Yeah, well, thank you. Yeah, it was the asymmetry that the symptoms left being were affected by the right. And when it comes to these elective type trauma cases where they're not there in the ED and you have to take care of them right away, I like to get as much information as possible. It's like getting an EMG on a patient who's had a disc herniation for 12 months, understanding objectively if they have chronic changes to the nerves. For me, gives a little bit I have more ammunition, and when it post-operatively don't get better, saying, well, this was there pre-operatively. I think if you do it post-operatively, you're then chasing your tail of, well, was this because of positioning in the OR? So
yeah. No,
yeah.
smart, but although his cord signal change, both ventral and dorsal parts of the cord are a little more left worse than right. So, I don't know whether I would have pursued it to that level, but I think it was a good thing. Hey, Jens asked the question of whether you thought about getting a CT angiogram before operating with this injury.
Yeah, thanks for bringing that up. Yeah, we had a CT angiogram, and I think any patient who has my recommendation is if there's any patient who has planned upper cervical C12 screws, I would highly recommend getting a CT angiogram so you know where the vert is. And many times we will sacrifice a C2 nerve root for access to place the C1 screws. But I know of a case where that happened and the vert infolded and the vert was inadvertently sacrificed and the patient died. So the more information, similar to the MR neurogram, the more information you have preoperatively, the better.
And a great case, very insightful and nicely managed. So these atypical Hangman's fractures are always a little bit of a bane of the existence. I want to echo what Randy Davis said. So follow-up for these. Would you think that if we have a non-surgically treated C-spine trauma, even thoracolumbar trauma, we should get an upright X-ray whilst the patient's still in the hospital, just a lateral, to see how the patients structurally adapt to this injury? Would this have been retrospectively caught with an early upright X-ray?
I think yes. And in some ways, they had the upright X-ray with the brace, but they were not planning on treating it surgically at the local hospital. So this is always planned on being sent out. But yeah, I think all patients should have an upright. And if you have the capacity to take care of the patient then and there, I would do so based on a finding of instability.
Yeah, and I think like the close follow, this patient had to, cross across different systems. But for these patients, even though like for a lot of these patients, when we say like we're going to pursue non-operative treatment, maybe not for this one, but for another patient, usually we'll get the baseline upright X-rays, as you're saying, Jens, and then bring them back in a week to see if there's any early change. And if it's someone who can't follow up in our system, we'll sort of counsel them and say, hey, you actually really need to see someone when you get back home at about a week's time. So
Yeah, I absolutely agree. I have a very low threshold to see them even weekly or every other week if I'm very concerned about them initially.
Ashraf and David, before we go on the next case, I want to ask you about this type of brace. And do you think this may have been prevented by putting the patient in a halo, or is this C-collar with an occipital extension sufficient to immobilize the axial cervical spine?
yeah, to be honest, I'm not terribly familiar with this brace. I think, once we start talking about halo, we're talking about, a procedural or, intervention, right? So, and I think if you were going to treat this with a halo, you probably would try to improve the alignment a little bit better. So it's sort of, but I think, yeah, were these the initial ones, the initial uprights, or were these the ones when they first met you, Alekos?
No, this was when they had uprights in the collar in Tahoe.
Okay. I mean, to be honest, I would, you have a little bit of subluxation. So if you look at the posterior body of C2 on C3, that's different than, than the alignment on the MRI or the CT scan. I think 2 slides earlier here, you could see here that the CT is, that they're lined up, whereas there is some translation. So,
I think that's a very good point.
yeah, as to how much translation you accept and how you counsel the patient, I think, that's, up to the provider, and, and there was probably a discussion, there. But I'm always a little bit wary if I see early translation, so I think I probably would have been a little bit more, not, pushing the patient a little bit more towards operative intervention, because it seems like it's mechanically, misbehaving. But yeah, as to like if you're going to treat it with a halo, then you see what alignment you could get in the halo. If you're able to maintain acceptable alignment, then I think that would be a reasonable option too. Alex, I did have a question for you actually. Like, so when you were thinking about, because we're trying to get this fracture to heal, and this patient, you treat a lot of patients who have, had, malignancies in the past. Like, how do you think about like bone grafting options, or in someone who's had like a previously irradiated field?
Yeah, it can be challenging. And if I have the opportunity to If I know the radiation oncologist who treated the patient, I will reach out to them to see where the radiation field was. That's number one. Number two is if a patient has an active malignancy, then I will not use a bone fortifying medication off label. I'm a little bit more loose with the use of it in patients who have a history of it. Now, so I will use that more judiciously, I think, than others. I'm not advocating for it, but that's just my practice. And then if you don't want to use that, I think taking bone graft from a remote site, saying do an iliac crest bone graft posteriorly would be a nice way. You can do a cortical strut if you want to try to get that across the C12 ring posteriorly. You could, so I think there's a variety of options. But yeah.
Yep. Yeah, great.
All right, thanks.
All right, maybe we'll move on to the next one here. Let me get us
Okay.
here, and then David will.
Okay. Do I have control?
I think you do now.
I think so. Okay. Awesome. So thank you everyone who's here today. I'll get started with the second case. So we had a 23-year-old male who was involved in a motor vehicle crash at 4:30 in the morning with isolated neck pain, as well as bilateral upper and lower extremity weakness and numbness. He presented at 5:30 in the morning, no other medical history, no other injuries. On exam, he had 4 out of 5 left upper extremity in his biceps and deltoid, and otherwise nothing in his bilateral lowers and nothing in his right upper. His pelvis was stable. Here we have the CT of his injury. Looking at his CT over here, you could clearly see that he has C5, C6, flesh and teardrops or burst fractures. And here on MRI, you could see that he has a significant spinal cord injury. Now, considering that he had some biceps on the left side, I treated this as an incomplete. In my mind, a moment. Oh, so due to it being an incomplete, the first question that came to mind is what the timing of surgery should be. So I honestly canceled my clinic immediately and took him straight to the operating and decided to take him to surgery. But really, the bigger question that I had in my mind was whether to give this gentleman steroids. So his injury was at 4:30 in the morning. This was maybe at this point 7 or 8 a.m. Incomplete injury, young person, no other injuries. In my mind, this justified giving him a dose of steroids. Then the next question that I had in my mind was what approach to do. Should I go front? Should I go back? Which one should I do first if I do both of them? So I figured it'd be easier for me to decompress him from the back faster. And on top of that, I often like to delay surgery, delay corpectomies in the acute phase due to significant bleeding, particularly in the cervical spine. So my initial approach was this C2 to T2 with a big decompression. I used an ultrasound to verify that the cord was indeed decompressed. And then at this point, a few days later, I returned and I did an anterior reconstruction with a 2-level corpectomy and got a very good decompression. This patient was part of a different health system, so I couldn't follow up with him, but I was called by his physiatrist at his rehab center who was actually saying that he was starting to walk with a walker. And so there are a lot of nuances in this case that I'm sure we could discuss about, but that's that patient.
Wow.
Yeah, there's certainly a lot of questions here, David.
Yeah.
Yeah,
I'm not as close to this as I used to be,
Yeah.
but obviously the first line of treatment for this kind of fracture is reduction. I mean, in the ER, we would put these people in traction. You can't really tell whether it's a complete or incomplete injury until the return of
Yeah.
spinal cord reflexes. So you don't really know whether it's complete or incomplete. It's not the worst intrusion in the canal that we've seen, but at the time of the fracture, I'm sure it was a completely obliterated canal. You're seeing the effect of where the bone sponges back after the injury. I don't know, Jens, you're closer to this than we are. Or yeah.
Yeah, no, this is a great debatable case because it's obviously one of those things where you make up your mind very early, and this is a very decisive treatment, shall we say. The general trend of cord injuries, cervical cord injuries, to go actually posteriorly, because we can go higher and lower than the injury, and really decompressing the cord, letting it unswell is a big deal. You can also, since there's a coronal component to this, as I saw on the CT scan, get a better realignment of that than with a 2-level corpectomy or so. So I actually agree with David that this was, while super aggressive from posterior, probably the right thing to do. And you can argue about 1 or 2 more levels above or below, but in the big picture, the preeminent thing in this young man is that he's facing a cervical cord injury at around C6 level, and anything you can do to get that better is okay in terms of not sparing motion segments. The only question I have is it really necessary with a multi-level posterior procedure like this to actually go anteriorly? And if then doing a 2-level anterior corpectomy with a metal cage. The final quid for me is, I think I said that in a previous interesting case discussion, I've stopped doing these titanium cages without a plate in the front because the esophagus wants to grow onto that thing. It can scar down. So that's my only foible there. I would probably have done a fibula graft and not needed a plate. But the question I have then to David is, was it really necessary to do an anterior corpectomy? Or could that have been dealt with just by letting that heal indirectly? Because you got a beautiful reduction with that. You have a multi-level, I assume, 4.0 rod fixation. So that's my one question.
Yeah, I
But
mean that was a good question. I mean, it's kind of one of those things. I knew I had a good decompression from the back, but he had two vertebrae that were incompetent in the anterior column. There's some retropulsion, and maybe part of this was just treating myself, knowing that there was nothing pressing on the cord, and I gave him the best chance for recovery. But no, that's why that's one of the questions.
If I
Any
can,
long-term follow-up?
So I did not, but what had happened was, as I said, one of the people from the local rehab center actually gave me a call because they wanted to know what I was thinking, giving this person steroids in a positive way. They said that they hadn't seen steroids used for quite a while in the Bay Area, and they just wanted to compliment me.
So David, can you take us actually through like what things like did you weigh, in terms of like giving steroids and like why this patient?
So if you look at at kind of the literature, if you look at all the NASCUS 1, 2, and 3, um, there's some evidence which isn't super, super strong, but it suggests that you could get on average 1 level of function back. So first of all, this being a cervical spine, 1 level of function is a lot. This person's injury was at C6, going from C6 to C7. Now you could use a manual wheelchair as opposed to a motorized one. In addition, the downsides for high-dose steroids in the literature were multi-organ effect, particularly pulmonary issues. And particularly in the elderly. So with this patient being young, this being an isolated injuries, his lungs being fine, the fact that an extra level could mean a lot for this patient. And then on top of that, it showed that the efficacy of steroids for this one level would be if you gave it within 8 hours of injury. And we had this patient within 2 to 3 hours of injury. So while I don't commonly give steroids, I will on some specific situations, and this person kind of checked all the boxes.
What did he ultimately get back?
Again, I didn't see him personally, but his physiatrist said that he was ambulating with a walker and he was getting strength in his legs back.
Oh, okay. That's impressive.
Was it steroids? Was it him being young? Was it but I'll take it.
Yeah. It was a good hunch that he was incomplete. That's great.
David, how long between when you do the posterior and the anterior?
Usually I like to wait 2 to 4 days.
One thing,
Yeah,
I think I agree that doing the posterior first here, and then staging the anterior would be reasonable, and it was the right thing to do. I think in the interim, you could always consider getting an MRI to see, what the decompression looks like, and if there is any residual cord signal or cord compression from the front. And I think like Jens said, doing the anterior was icing on the cake, but may not have been a necessity unless there was persistent compression. I want to ask you, what was your decision about not putting a plate on?
honestly, I felt like I got a good fit against the end plates, and I feel like the posterior instrumentation in a way acts as an equivalent to the plate. And I do think that some of the dysphagia we see after anterior surgery has to do with the retraction on the esophagus when putting a plate on, and especially with this patient who had a pretty significant injury. I wanted to minimize the risk.
Can I just throw another opinion in here, just dusting off my admittedly pretty shabby old Rancho hat, thinking on rehab, worst case scenario would be you have a young guy with a mid-cervical complete injury, and neck mobility would be very important to him. So I think in the Rancho days, looking at that, we might have gone anteriorly first and fought the more aggressive blood loss that you can encounter, but that way limit his fusion to just the 3 segments, the 2-level corpectomy, with anterior and probably back it up with posterior fixation, but just over that segment, and then hopefully get the same neurologic improvement from decompression. But if you didn't, that way the guy would at least have some more mobility in his proximal cervical segments. But there's more than one way to approach it, and there's pros and cons for both. So I think it's a great case for discussion.
Just for academic sense, let me follow up on Alex's point about the plate. For the other gray hairs on the faculty, do you think a plate, is there really good evidence that a plate increases the amount of dysphagia more than just a big anterior approach to put in a corpectomy cage and just the swelling from that? I don't know that I'm really convinced that a 2 millimeter plate makes that much of a difference if you can get additional fixation, which obviously you didn't need here. The cage stayed in place, home run, you got a fusion, you got a stable spine. But I don't know that I buy the plate argument.
Yeah, and maybe not. I don't know.
Yeah, I think I think in my mind, and this is just to throw another, sort of non-evidence-based sort of thought. I think there's potentially a difference between using an expandable cage and say just something like a fib, something that has a fixed length. Because right now I think like, I mean, it's fixed posteriorly, so you're pushing against, a fixed height essentially. So unless, my question for the people who are advocating for a plate, is the reason just to prevent the cage from kicking out anteriorly, or?
Uh, This is Jens. I would have put a plate on again, as I said earlier, just to prevent the esophagus from scarring down against that cage, which is a problem or has been a problem in the past. And mechanically, it just adds icing to the cake. I totally agree with Scott. The question of the dysphagia is a question of esophagus release and retraction, severity, and duration. And so it's a dissection related thing. I do not think that anywhere there's actually a true problem with plate fixation causing dysphagia. The dysphagia comes in elderly patients when you're in the upper C-spine from the cervica, the upper pharyngeal plexus being retracted and too long. So plates per se are not a problem in that regard. I would have to put the plate on to protect the esophagus from the plate to keep those separate and to have them mechanically totally stable. That would be 10, 15 minutes extra work. That's my only reason for that.
And I think that those are fabulous points. Thank you.
All right. So I just want to get maybe Dr. Ziegler. So it's 48 right now. Should we try to make it through one more case, or?
Yeah, I think you should, absolutely.
Okay.
These are great cases.
All right. So here, all right. Yeah. So this is the third case here. So we'll keep this a little short. So this is an 81-year-old woman who was going out at a restaurant. She had a ground level fall. She had some loss of consciousness. She had no antecedent chest pain. She had been having some dizzy spells for some months, but she was otherwise pretty active. Her past medical history was, I mean, she was actually pretty healthy. And had regular, encounters, had a primary care physician. So she wasn't healthy because she had undiagnosed issues. She was truly healthy. Had some hypertension. She lives with her husband and her son, and no bad habits. When she first came in, she was hemodynamically stable. She was moving all extremities. The only thing really on a pretty comprehensive exam was just some C-spine tenderness. Again, neurologically intact. In terms of our initial imaging, she did have some, some hypodensities in the white matter of her head, but nothing acute. And her chest, abdomen, pelvis was otherwise negative. And so these are her images here. So we'll spend a minute here to sort of get our bearings. So again, I usually start off with the sagittals. So on the left sagittal here, the OC joint is intact. But clearly she has a dislocation of the C1-2 facet. So the C1 has sort of gone anteriorly on the left side. Midline looks reasonable. There's some focal kyphosis here. And then on the right side, there's a pars fracture. And then on the coronal here, you can see the dislocation on the left side. There's no bone underneath this, the C1 lateral mass. And then on the axials, this is sort of what, it really helped me to figure out what's going on. So the anterior and right side of the ring of C2 sort of collapsed forward relative to C1. So essentially, it's a pretty atypical. It's like a hangman's on one side and a C1-2 dislocation on the other side. This was the MRI that we had. So the question is, do we need an MRI or not? She was neurologically intact. I was just concerned about, I just want to know how much space the cord would have, because it would just give me a sense on, how I could plan my reduction and that sort of thing. So what we did sort of elicit was that there were bilateral vertebral artery irregularities. Yeah, she did have quite a bit of edema here, but overall, there was no active cord compression, which, again, we knew from her exam. In terms of her clinical course, she did have her EKG had shown a right bundle branch block, but she didn't have any prior EKGs because she was otherwise pretty healthy. And so the question is, what do we do for this, from patient positioning, from, our discussion with anesthesia. And so initially, my plan was to, after she was asleep, to do, to see if we can get this reduced with traction. I was pretty optimistic that I'd be able to, after putting some neuromonitoring leads. The question is to whether to do it awake or asleep. I think the most conservative thing would be to do this awake, in a patient. But I think there are issues with like patient anxiety and that sort of thing. So initially, we did an awake intubation, and then attempted a closed reduction, which was unsuccessful with serial weights only up to 40 pounds. This was in the upper cervical spine. So, when the injuries are far lower, we'll go up a lot, to a higher weight, particularly if someone's awake. And so we attached our neuromonitoring leads, and then turned the patient prone and did a C1 to 4 PSIF. And then in the course of that, she did have a traumatic dural tear, which was the result of this spike here. And you could sort of see there's a hint of the efflux of the CSF on the MRI. And so on that left side where the facet was dislocated, ended up sacrificing the nerve root, so that I can put a Penfield 4 into the facet and sort of and hinge it back, which was done in combination with an intraoperative Mayfield adjustment. So it did require having another provider there, in addition to our resident. And then did C1 to C4 fixation. In terms of the length of the construct, the thoughts that go into it are, how do I really define the proximal segment and how do I define the distal segment? My proximal fixation is, if we go back to here, is on the left side is really just the C1, is a C1. And then on the right side, it's the C1 screw as well as any threads of the C2 screw that are on this side of the fracture here. So this is what she ended up with here. And then you could see, we could judge our reduction here with the C2 ring. So we've reconstituted the ring. She has a little bit of a hyperextension here, which I was okay with. Yeah, so she remained intubated overnight, and then we transferred to the floor post-op day 2, and then out to rehab by post-op day 4. At 4-month follow-up, by that point, she had an interval pacemaker placed for her 3rd-degree heart block, which was the presumed cause of her fall. She had persistent right C2 numbness. It was the left C2. Which is the one that I sacrificed in order to access that joint, but otherwise was intact. And at 16 months, she was actually still bothered by that nerve root. So I think the question, sometimes comes up, do we sacrifice that nerve root or not? I generally don't. But I always, anytime I'm sort of operating sort of in between C1 and C2, I will tell patients ahead of time that there's a chance we may take it, especially if we run into a fair amount of bleeding, so that they're not surprised by the numbness later. It tends to be less symptomatic in our older patients than our younger patients. But yeah, sort of open it up to questions.
That was a phenomenal reduction. It was really, really nice. And it's not an injury to be taken lightly. There's a certain mortality rate to fractures in people this age. It's just interesting. The mechanism of injury of this was usually more of an axial loading. It's unusual in a ground level fall. But I can't argue with the outcome you got was really a fantastic and just beautiful reduction. Good thinking, good logic.
Thank you. Yeah, I mean, I think, we could rely on the mechanism, but sometimes, it's like what to do when the injury is discordant with the reported mechanism. We still have to treat what we're seeing. So I completely agree.
No, well done. Very decisive. And again, sacrificing that root in that situation is absolutely a no-brainer there. I think that was very well done. I mean, that's pretty substantial dislocation is unlucky. What did you do postoperatively for the births? I mean, so there was what sounds like a biffle injury on both sides. Was that patient, did the patient get TCDs afterwards? Did you put her on a protocol? Did you get an MRA afterwards? How is that managed?
Yeah, so generally with these injuries, we consult our neurocritical care team, who really guides the duration of anticoagulation. And the other factors for her were her new, cardiac diagnosis. In general, what their protocol is they'll repeat imaging at 3 months. So they'll recommend anticoagulation, usually at least aspirin, depending on the grade of the injury, and then get another repeat imaging at 3 months. But I do think that, we can grade these injuries, but I think there's still a little bit of uncertainty as in terms of the optimal sort of anticoagulation and duration. And of course, it needs to be weighed with the patient's other issues, like the other reasons for them to be on anticoagulation, whether it's AFib or that sort of thing. The question I sort of have for the group is, what do we, just like what to do for sort of bone grafting? Do people generally decorticate the C1-2 joint or not? How do you factor that in, especially in older patients versus younger patients? This patient was, even though she was healthy, she was on the older side. So I just, sort of did some, the local bone autograft and some morselized, but didn't really put anything into the facet joint there, although I just wanted to see what folks' thoughts are.
So if you have the C2 root sacrificed anyways, it's a wide open joint, and I will decorticate that. The two options are if you want to go cheap, and since you've sacrificed or you've gone above and below the C2 spinous process, you can take a small sagittal saw, cut that down the middle, split it. I've seen in Japan, you have two perfect grafts that you can literally wedge into the C1, C2 joint. It's an actually beautiful, small little structural graft. You can bill as that even. The other option is I use a allograft ACF spacer, 6 millimeter, again with a saw, split it down the middle. The cortical part fits perfectly into the C1, C2 joint, and then I just sharpen it up with a Midas and then tap that in. It's actually quite a gratifying graft to put that in, and you can literally put the C1 in a compression down onto C2 then. So the Medicare thing is the C2 spinous process in a setting like this, and the luxury one is to split an allograft ACF spacer and tamp that in. Those are my thoughts. Anybody else?
I think that's a very elegant solution. And then Jens, just correct me, I assume you're doing this before the C1 screw goes in, because the C1 screw will block your visualization.
So I'm actually a proponent of the so-called palm screw, posterior arch lateral mass screw. So I don't go through the base of the lateral mass. We put a Penfield 4 on top. We published that in Journal of Neurosurgery Spine with some diagrams. We put up, and we're not the only ones who've presented, so we got a lot of flack from people because we didn't do our literature search carefully enough. But basically, you don't have to dive deep into that plexus or sacrifice the root. We put the Penfield 4 on top of the arch of the C1, and with that protect the artery. We then put a Penfield 2 below the arch, so we protect the C2 root, and then we drill out the posterior arch right to the base of the lateral mass, and then from there have an absolutely perfect straight shot towards the tubercle. So I actually preserve the C2 roots. The orthopedic surgeon, my partner, Dr. Skuyan, does what you do. He burns the bejesus out of it and sacrifices it. But I like to preserve it, and I do these palm screws instead of the lateral mass screws.
Yeah, no, this was the one time I took this nerve root in the last 5 years. But you could see here, like generally do something similar where like for this screw here, we drill through the posterior C1 ring for access in general. But.
Well, those are great cases, great discussion, and you guys, you did what we expected you to do, and you came through. So thank you very much. Jens, you want to say anything else nice to these guys? You got to go back to work.
No, it's so cool to see you guys. Fantastic quality work, and really a lot of good discussion points and insights. I second what Jack said. Always a pleasure to have UCSF there, and you guys really raised the bar for all of us. And from the initial survey overview to the more detailed nuances of trying to work your way through the vagaries of spine trauma care, really insightful program. So thank you so much.
Thank you for
Thank
having
you,
me.
everyone.
Appreciate having us.
Have a good night.
Yeah.
Take care.
Bye.
Bye-bye. Thanks, Corey.
Thanks, Dr. Ziegler. See ya.
Bye-bye.
Bye.